So thanks very much, and it's wonderful to be here. I've thoroughly enjoyed the conference, and coming to Seattle, I've been asked to speak on the topic of sudden cardiac death ICDs and LifeVest. I've always wondered in talks where the person says, I've been asked to speak on it. It's like, you know, what's the issue? And you know, if you said, bring whatever talk you like, it might have been a little bit different, but this is one of my favorite topics, and I like being tasked with it, and I'm gonna try and stay on track and make sure that we cover ICDs as well as indications for the LifeVest and opportunities to use that. So this is my disclosure slide. I don't make a lot of money from the companies, but I do have involvement with several of the companies. We're a training site for St. Jude CRT implant and also for S-ICD implant with Boston Scientific. So we do receive some small remuneration for that. So the question is, what is sudden cardiac death? And we've had lots of talks about this. It is essentially ventricular tachyarrhythmias, ventricular tachycardia, ventricular fibrillation. That's 80 to 90% of sudden cardiac death events. This is a situation of sudden hemodynamic collapse, which is then later followed by the death of the patient. And again, that's usually ventricular tachyarrhythmias, most of those in the setting of coronary artery disease. We have to recognize also that if you have a massive myocardial infarction and your heart just can't beat because the pump is so compromised, that's also sudden cardiac death, as well as bradyarrhythmias where simple pacing might solve. So those also fall into the category. If it's the ventricular tachyarrhythmias and you apply the AED in your airport or whatever else, that's when the device will say, stand back, we're gonna shock. If it's the acute MI with pump failure, the device will tell you resume CPR and call emergency medical services. So the slide on the left kind of illustrates the concept of the CAD, and basically what we're doing is we're getting to situations of ischemia and scar. Once you have ischemia or once you have scar, your myocardium is electrically vulnerable to tachyarrhythmias, which could then cause sudden cardiac death. So basically you develop some atherosclerosis, non-obstructive plaque, and should that plaque rupture for any reason, you can have acute thrombus deposition on the plaque, which then results in a heart attack, which will then develop scar, which will then leave your heart electrically unstable. Or you can have chronic total occlusion, where the blockage just grows and grows and grows, completely obstructs. Downstream, you have an infarct, and now you have a heart with scar. As you take more and more hits of that nature, the overall pump function of your heart can also start to decline, which puts you at even increased risk. But any of those events, large or even minor, can cause electrical instability in your heart, resulting in a sudden cardiac death event. So here in the bottom panel, you're cruising along in normal sinus rhythm, and then suddenly you experience a PVC, and the next thing you know, your heart's 200 beats a minute, the contraction's completely disorganized, you have cardiovascular collapse, and you're on the floor, and you will die unless somebody performs CPR and defibrillates you. So this is the sudden nature of sudden cardiac death and how that occurs. And it's nice to have a mechanistic conceptualization of what's actually happening in our heart electrically when this occurs. So on the left, we see normal sinus rhythm, and this is nice planar linear waves of electrical excitation propagating across your heart, resulting in coordinated contractions. If you have a PVC, for example, on the tail of your depolarizing wavefront, you can have RMT type phenomena, which will initiate spiral wave activity. And if your electrical situation suddenly results in the development of a spiral wave, you have essentially ventricular tachycardia. And the more unstable that spiral wave is, the more it meanders or shakes about in the heart, the more polymorphic your ventricular tachycardia will be. The heart's now consuming a tremendous amount of available ATP. Its energy stores are rapidly depleting. Cardiac perfusion is compromised because the organ's beating so fast. Ischemia is developing. That will promote even further electrical instability, and chances are high that your monomorphic ventricular tachycardia will become polymorphic and finally degenerate into frank ventricular fibrillation, where you have independent wavelets of electrical excitation coursing throughout the myocardium, resulting in a totally disorganized contraction pattern. And if you've ever been in a cardiac OR, when the open heart patient goes into ventricular fibrillation, the myocardium is said to look like a bag of worms, just writhing, no coordinated contraction. And if you see it, you're like, oh yeah, bag of worms. So I know what that is. And that's ventricular fibrillation. You need to defibrillate. And so this is sort of the conceptual framework that we should have in mind when we talk about ICDs, ICDs have the ability to form anti-tachycardia pacing before they defibrillate. And they'll do that in this case of the monomorphic VTs. They'll be able to pace into that. And if you pace into that spiral wave, chances are by pacing, you can overdrive it, interrupt it, leave the tissue in advance of that spiral wave refractory, and the reentrant activity will stop, and you can restore normal sinus rhythm that way. Should you not succeed, you have to go on and receive the defibrillation. So let's understand our risk for sudden cardiac death. How many people a year in this country die of sudden cardiac death, like we just described? 300 to 350,000. It's like 3 jumbo jets a day crashing. That's sudden cardiac death, and that number is very close to what other number that's very important in healthcare? That's deaths in hospital due to inadvertent medical errors. Also about 300 to 350,000. So all the drugs that we have in hospital, all the things we do, these are potentially weapons of mass destruction. And if we use them inappropriately, we can result in the demise of people. And this is happening nationally, and the academic medical centers are no more exempt than the outside hospital. So things we just need to be very conscious of. But back to sudden cardiac death, who has the most sudden cardiac death events? On the order of hundreds of thousands. These are people who don't have heart failure. They don't even have known coronary disease, but they probably do. They might have had a silent myocardial infarction that's never been detected. There's a little bit of scar, a little bit of electrical instability. These are the people on the order of hundreds of thousands who will die of sudden cardiac death in our country. We have no way of identifying them clearly and no way of offering them adequate protection. As their disease progresses to where the ejection fraction is actually depressed, or they've had an arrhythmic event and survived it, or their ventricular function is depressed and they've had sort of sustained arrhythmias that are scary enough, now they meet guideline criteria for ICDs. They are indeed the cohort that will benefit the most. They are the smallest number of lives that will actually save with defibrillator protection. So let's realize that the vast majority of victims don't even meet guideline criteria for ICDs. So when you meet somebody who meets guideline criteria for an ICD, you should offer that person the therapy and encourage them to accept the therapy. Okay, we have to sensitize people to the gravity of the situation. So here, this iceberg represents the 350,000 people who will die this year from this. Those below water are the ones we can't identify. Our guidelines don't account for them. The iceberg above water represents the people who do meet guideline criteria for ICDs, and only about 20% of those are we actually offering the therapy to. So our guidelines fail victims, and healthcare providers fail those who do meet indications. So let's just review quickly what are the guidelines for ICDs. So primary prophylaxis, you never had an arrhythmic event, but you're at risk. If your ejection fraction is less than 35%, and that's after 3 months of optimal medical therapy, which we've all been talking about here, you qualify for an ICD if your ventricle hasn't recovered above 35%. That is true for ischemic cardiomyopathy, that's true for non-ischemic cardiomyopathy. The Danish trial has recently questioned the role of ICDs in non-ischemic cardiomyopathy. Not enough to change the guidelines yet, and we'll see where that takes us, but that should at least sensitize us to the fact that the ischemics are at higher risk than the non-ischemics. So we appreciate that, but right now our guidelines say implant both. And then we have to appreciate what's this 3 months of optimal medical therapy and where did that come from? It's not a scientific number. That's a number that was given us by CMS. So CMS says we're not going to pay for the ICD until you at least treat for 3 months. A number they pick kind of out of the air. It's actually a decent number because it kind of makes sense because often you'll see a good amount of LV function recover in 3 months of good medical therapy. So it's useful, but let's remember that number is artificial. Nevertheless, we're bound by it. I think the sad situation is where you have the ischemic who's got an EF of 25-30%. When you identify him, you give him a stent, and at 3 months you re-echo him, and the EF is now 35-40%. Just outside of criteria. You have this super high-risk individual, but you've just moved him out of criteria for his ICD, which could well prove to be life-saving for him downstream. And then secondary prophylaxis, you've had a sudden cardiac death event, we've resuscitated you. We can give you an ICD as long as you're over 40 days post-MI. So if all this occurred in the setting of an MI, you have a positive troponin, it was an NSTEMI, you have to survive for 40 days. And that was a result of the definite trial from 2004, where they put ICDs in people post-MI, but the cohort they choose was so sick that a large number of those people died from their MI, and therefore the ICD benefit was not demonstrated in the trial. Those who received an ICD and didn't die from their MI were saved by their ICD in a statistically significant way. But the guidelines now get the definition where we have to wait 40 days post-MI. So this is going to start to bring us into the role of the LifeVest. Are people at risk during these 3-month, 40-day waiting periods? Yes, they're at risk. Should we offer them protection? Probably we should offer them protection. How can we offer them protection? We can fit them with LifeVests while they're on their optimal medical therapy, and that's going to be a strong indication for using the LifeVest. And I'll tell you how that got into guidelines and why the guidelines are a little bit deflating, but at least that opportunity is there for us. So let's just appreciate how far we've come in terms of ICDs. ICD therapy began back in the 1980s. Epicardial patches sewn on the heart, big pulse generator in your abdomen because it was too big to fit pectorally. You had to have survived 2 events to qualify. So these were secondary prophylaxis people, had to survive that twice to receive an ICD in the 1980s. Then kind of in the mid-90s, we evolved to the Transvenous ICD, which is the popular ICD that we're all familiar with. You know, it sits in the pectoral region, lead through the veins into the heart, and those have been implanted on the order of millions. That's kind of what we think of as an ICD, and it's a good starting point. As of 2012, we have another ICD option, and that's the Subcutaneous ICD, which is now owned by Boston Scientific. It's under your skin, but it's outside your thoracic cavity. Nothing into the heart, nothing through your veins. It's just under the skin. It's able to provide you with defibrillator protection. It, in fact, works very well. It can't pace you, which is important because sometimes you need the pacing function of an ICD. But one barrier that we'll see, or one challenge we'll see, is that you never want the ICD to pace you very much in the ventricle. So if you have an ICD that is going to require, a patient who's going to require a certain amount of pacing, you have to choose your pacing strategy from your ICD very carefully. Because what's the cutoff now for pacing burden that will provoke a pacing-induced cardiomyopathy? When should we expect it? What's the cutoff? A lot of people have 40% RV pacing in their minds. The latest data from Penn is 20%. So if you plant a single lead ICD in the ventricle, you better be sure that that person is not going to need pacing from their ICD. And if they prove to need pacing from their ICD, we'll talk about strategies for how to manage that. But speaking of weapons of mass destruction, leaving that ICD pacing a compromised ventricle is a very high-risk situation. So here is a standard ICD, single lead ICD. Lead is transvenous, implanted in the RV apex. We used to implant dual coil leads. Now we almost exclusively implant only single coil leads because the dual coil will not add you much in terms of your defibrillation thresholds, but it will create a very high-risk situation for lead extraction down the road should that patient ever require it. So if you put a dual coil system in somebody, you are screwing them if later in life they need that thing extracted, because it's now very high risk for extraction. Single coil, much better risk, much more manageable, and probably providing you all of your defibrillator efficacy. And that's where my job comes in, to make sure that single coil system works. And it's all about lead position. That coil has to be in the base of the RV apex, really advanced, in the base of the RV, the inferior wall of the RV more appropriately, all the way to the apex. So if the shock vector goes between that coil and my can, it will encompass the bulk of the myocardium and actually be able to defibrillate it. I've seen some x-rays of ICDs at this conference, which looked really scary because they looked really high in the heart. So should they need to shock, they're going to, in fact, miss a large majority of the myocardium and therefore be ineffective. So single leads is what CMS is encouraging us to implant. Only implant an atrial lead, really, if you need atrial pacing. That's really the only good indication for it. It doesn't help the device discriminate against the type of rhythm well. So differentiating, is it really VT-VF? The second lead doesn't help the device very much. It helps us in reviewing electrograms to decide what it is. So we like to have it. CMS encourages us not to implant them unless they're needed, and really the only indication for it, in my mind, is atrial pacing. So if you have somebody who needs a pacemaker function from the atria because of chronotropic incompetence, you can implant the atrial lead. And leads are, the Achilles heel of the system, really, because as the panel on the right shows that, at 10 years, there's 20% rate of lead dysfunction. So we're all programming around these, deciding whether we're going to extract, reimplant a lead, what to do, because lead dysfunction is a problem. So that's a challenge for us. So here is a single coil ICD that we implanted earlier this summer, and this has the unique function of having an atrial sensor. So I can't pace from the atria with this, but in the single coil system to the ventricle, at least I have atrial diagnostics. Again, doesn't help the device very much, but is very nice for me in finding AFib, SVTs, things of that nature, confirming that VTs are really VTs. And the big arrow there is pointing to the little sensing dipole, which sits in the atria and provides me with that information. So that's a Biotronic product, and I've found it to be advantageous in several settings. So ICD implant complications. The reason why CMS is encouraging us to implant single leads whenever we can, and why we should be concerned, is that ICDs have implant complications, and that's higher for single lead systems than dual lead systems. So here this graph shows sort of 30-day complications. Statistically significant are pneumothorax requiring a chest tube. Everyone's allowed at least one in their fellowship. 2 is okay. 3, maybe you picked the wrong specialty. Cardiac tamponade, if you do in fact perf the myocardium, and I was in this situation in my first year of practice, it happens, that's also statistically significant in the first 30 days. At 90 days, mechanical complications of the device requiring revision, any complications statistically significant. So around the implant, we have to deal with device complications or procedural complications, whatever happens, and let's be aware that that does in fact happen is the case. Another study I'll show has shown that the skill of pacemaker implantation in the United States has in fact declined in the last 10 years. So there's more complications from device implantation rather than less. You think we'd be getting better at this? Some data suggests that we're not. So incentive then to get the device outside of the heart, outside of the vasculature, so we can avoid all these complications. So now we have the Subcutaneous ICD, approved in the United States in 2012. Big pulse generator that sits laterally on your rib cage, and there's a picture of it there in the middle, how much bigger it is than the others. But you have a much more robust lead. It's in an environment that doesn't nearly have all the hemodynamic stresses. Big battery, discriminates SVTs, AFibs very well, so it provides very appropriate therapy. It can't pace you, and right now the diagnostics you get from that device are crappy. You wish it'd give you a lot more telemetry data, which it just doesn't do, even though we're on the second generation. So now battery life's up to about 7 years, and these can be very appropriate. Who's the best friend of the S-ICD? Meth user. 20-year-old kid, all this potential, thin as a rake handle, no teeth, EF 10 to 20%, non-ischemic cardiomyopathy, And they're very thin. You can actually see the leads sort of bugging out through their skin, but we've used it in that context more times than I would like. So just some S-ICD features. Again, position is everything. We really need that pulse generator to be on the mid-axillary line, right at the level of the apex, outside the body, because the shock coil is going to be anterior to your sternum, and when the device defibrillates you, you want all of that energy to actually go through the myocardium so that it shocks the person out of their rhythm. So this is what it looks like, and you can see that on X-ray, on the PA and lateral, it's at least at the level of the apex. It's mid-axillary in the lateral X-ray. You sort of have 3 scars. You can make those smaller and smaller the better you get at this. And we actually don't need this scar anymore, so we can just tunnel up here without actually cutting down to secure the lead. So it's getting a little bit more elegant. And here's a little newspaper piece, because social media is everything, about our first S-ICD in the Tri-Cities in a peripartum cardiomyopathy patient, and that was in 2014. So my S-ICD plant, it's all art and drawing. So we put the patient under general anesthesia, and then we get our black markers under fluoro, and we mark where the apex is, pulse generator right there, sufficiently posterior, check with fluoro, draw lines around things. We know exactly where we want the hardware. Then we prep the patient, and actually the cut in the implant then goes very quickly. And probably the most the most hair-raising part of it is the what we show on the right panel there, and that's where we put this tunneling tool from our xiphoid incision down to the lateral pocket. You just kind of feel with the tip of your finger, make sure it's sliding over the rib cage and not going under your rib cage to give you pneumothorax. That's a known complication. So you want to just make sure it's going well and that you're going to feel it come out exactly where you want it in the base of the pocket. Then you attach the lead to that thing, pull it through, and it's a matter of tunneling it up after that. Defibrillation threshold testing, the device can deliver a 50 hertz burst, causes ventricular fibrillation, DFT times are longer, charge times are longer, here 18 seconds. With our positioning and knowing it's perfectly positioned every time, we've never missed a DFT at 65 joules. The second shock is 85. We've never missed one at 65. And it's all about making sure that myocardium is sandwiched by that defibrillator system in that particular patient. So then you say, well, if the device can really be outside of your rib cage and just under your skin, then why does it need to be under your skin at all? And in fact, it doesn't have to be under your skin. There's the LifeVest. And the LifeVest is a clever device, defibrillator system under the left pec and in the back, 2 sensing electrodes, and a portable generator, battery that you wear on your belt. That's the computer and the battery. And that's a perfect defibrillator system. You could wear that your whole life if you were so motivated. You have to take it to clean it, things like that. So there's times when therapy protection would be interrupted, but it's wonderful ICD protection. And the beauty of it that you don't get with an implantable device is the battery is chargeable. So you just plug it in and charge it every night. You can't charge these. So we have all this conservative technology to preserve battery life. And the nicest thing about that is preventing inappropriate ICD shocks, which can be 8 to 40% depending on the series. 20% is a good round number. 20% patients will receive inappropriate ICD shocks, which can be devastating because it's exceedingly painful. They say it's like getting a horse kicking you in the chest, and patients will come up with these descriptions for you. So if this device is going to shock you, it will yell at you with the voice of God, saying, prepare to be shocked, everyone stand back. And I've actually been on the phone with a mother while her kid in the LifeVest was in the room, and you could hear the vest screaming out that it was going to get ready to get shocked. So what you can do, if you're conscious and don't need that shock, is you can press a button and abort the shock. Can't do that with your implanted ICD. So the rate of inappropriate shocks go way down because if the patient doesn't need it, the patient will simply abort it. And we can do that because the batteries are chargeable. And the telemetry data is also phenomenal. So a wonderful technology is this LifeVest. Where's the niche for the LifeVest? The LifeVest would like to prove that it is indicated in those waiting periods, the 3-month waiting periods, the 40-day waiting periods. If it could prove that it is a necessity in those waiting periods, it would have a strong indication and we'd be ordering a lot more LifeVests. So we'll see how that's played out. Again, ischemic cardiomyopathy, let's realize post-PCI, how at risk are you for sudden cardiac death? So we have a trial like the Cadillac trial to help us quantify that. If your EF is low and you have any other risk factor, you are high risk for a sudden cardiac death event in that first 3 months. So you should be protected. You'd think from the Cadillac trial. How much ICD therapy do you get in the first 3 months? So in the MADE-IT RIT trial, which was a reprogramming trial, in the first 3 months, 1% of those patients received an appropriate shock, and half of those were ischemics and half were non-ischemics. In the WEAR-IT2 registry, which is more recent, the LifeVest registry, prospective registry, less than half of those patients being ischemic, it was 2% at 3 months. So is it worth prescribing the LifeVest to protect our patients from a 1 or 2% risk during waiting periods? The Cleveland Clinic registry looked at that, and 85% lower mortality at 3 months. I think that was post-PCI. Yeah, that was post-PCI. So you've open blocked artery, the EF is low, you're waiting for them to recover, 85% lower mortality in their registry with the LifeVest. That's compelling. And then for patients who receive a LifeVest, how many of those, after those 3 months, will go on to get an ICD? That's kind of an interesting question, and that's been quantified. And the WEAR-IT2 data suggests that 40%. So you recognize that low EF, but you're locked in a waiting period. What's the chance your patient will qualify for an ICD and get one after that waiting period? About 40%. So it's a bit of a coin toss if you're going to go on and get the device. And this is what a device report would actually look like. This is a patient, 80 years old, VFib arrest, found to have hokum with a 94 millimeter gradient, normal coronaries. We referred him to UW for septal myectomy with ethanol ablation. That was not performed. They did implant a Boston Scientific dual chamber ICD, but we sent a UW on a LifeVest because he'd already had an event, and that event, he had another VF arrest, and he was appropriately saved by the LifeVest. So here we see how the device can detect that rhythm as the timing cycles end, and it's done recognizing the VFib getting ready to charge. On the report, it'll turn from blue to pink, and then you can see in the pink circle where the defibrillator shock was actually delivered, and the telemetry afterwards. So we're thinking about what to do with him, maybe Mayo Clinic for septal myectomy because he still has a gradient. It's a little challenging because there's a role for CRT and hokum to reduce gradients, and if you're not going to do it with myectomy, that might be the more appropriate device than the dual chamber ICD. And then telemetry data during that time. Here's a patient who just gave us a lot of non-sustained VT. Not enough to qualify him for a secondary prophylaxis ICD, but helps us manage him in adjusting medications to reduce VT burden during the waiting period. So the LifeVest can be handy for helping us manage our patients. Here are guidelines, Circulation 2016 for the LifeVest. If you've had an extraction, so we've taken your ICD protection away from you, then Class 2A, we should provide you with a LifeVest. If you're waiting for transplantation, 2A for a LifeVest. If you are in one of those 3-month waiting period or 40-day waiting period, there are only 2B recommendations. So not the strongest. And that's why I think the use of the LifeVest has, I think, dropped recently since the guidelines became available. It'd be nice if that indication was a little bit stronger, but that's what it was given. And my time's almost done. I'll just say a few more things because it's a heart failure conference. Someone needs an ICD, you also have to think, would they benefit from a CRT device? And this can be absolutely transformational therapy in heart failure. So if they have a wide QRS, 130 milliseconds with a left bundle, 150 milliseconds with a right bundle, you should be thinking CRT. For a CRT, you put that lead of the coronary sinus system out to the basolateral LV, and if you, with the left bundle, that's the latest site of activation in your heart failure patient. You now make it the earliest site of activation by pacing there, and you can recruit that LV myocardium, which is very slow to activate, early into the cardiac contraction. And you think, would that work? You know, you're making it earliest, it was latest. Is that really the best thing? It works phenomenally in the properly indicated patient who has a good lead position. So it's absolutely something to try, even though the resulting QRS is a little bit bizarre. We now have quadrupolar leads for CRT, which really helps with the implant and a lot of programming, but you have to know where those poles are. Which of those poles are really most basolateral and are going to give you the best therapy? I'm very careful to document that in my procedure report because I can tell under X-ray and fluoroscopy where the best pole positions are, and I'm going to forget, so I put it in the procedure report and say, hey, when you program this thing, these are the best poles, so that it's obvious in the device clinic. It is absolutely huge, because you will get people who pick poles that have better thresholds, they're not nearly delivering the CRT, and your patient who has a 50% mortality risk at 5 years is going to be much more likely to not respond to CRT, progress in heart failure, and die because the device was not well understood and not properly programmed. So we perform ECG-guided CRT optimization on every patient. You can tell from the ECG how much of the LV is actually being recruited into the contraction by how much the QRS changes relative to baseline. And we see this all the time. Patients referred back from whatever center, or you inherit a patient with a device, haven't really responded to CRT, or the response is really underwhelming, and you look at the ECG and you can tell that that lead is hardly capturing any LV myocardium. And they've been labeled a CRT non-responder. So you have to get your 12-lead ECG out and serially test different LV offsets, pacing earlier and earlier and earlier to see that ventricle become recruited into the electrical activation of the heart. So we do this in everybody, and you want lead 1 to be negative, so the electrical vector is really moving this way, and then positive in V1, so it's moving from posterior to anterior, left to right, and that's recruiting the ventricular myocardium. When you get that, you should expect a responder. It's really important. And sometimes you find out it's because the AV delay is way too long. They actually have really slick conduction across their AV node, and their own signal's just beating out the device. The heart's already completely activated before the device ever thinks to pace them, and therefore it's not doing very much. So you have to pay attention to these things. The only way you're going to make a positive difference and understand it is if you do it with a 12-lead ECG. So we wrote this article in EP Lab Digest last year saying the electrophysiologist's role in treating heart failure. So the EP needs to take responsibility for this and make sure that device is pacing in a way that's actually electrically beneficial for that patient. I think it's a little over the head of most people. But an EP should know to do that and should do it. And I always follow my own CRT devices every 6 months or a year and spend a lot of time tinkering with parameters. And everybody gets an electrical optimization at the time of implant and repeat in the office to make sure that vector is still the best as the ventricle is recovering. And the result is really can be transformational. So it's important to do and important to insist that your EP docs are doing this. You know, it's interesting, we have VAD clinics, optimize the VAD. We don't have CRT clinics where we optimize the CRT, and we should because it's a very expensive device and the potential for benefit is absolutely tremendous. I asked the question, what about His bundle pacing? We have a new technology. You identify the His signal, you can put a pacing lead right in the His bundle, pace right into the native electrical system, and often you can fix left or right bundle branch block by doing that. And there's trials showing that that is equivalent, as good as the traditional CRT pacing system. So that's something to think about. Not in the guidelines yet, but it's something that we are playing with as electrophysiologists. I might be more inclined to offer somebody that if I can't get a good traditional LV lead position at the time of implant. Here's somebody, weapons of mass destruction, a single chamber ICD, referred to you because the device is now at ERI, and it's been pacing him in his right ventricle 90% of the time. So no chance the ventricle is going to recover with 90% pacing burden. So if he's truly ventricular pacing dependent, that needs to be a CRT upgrade or now a His bundle pacing system. And here we show we recorded a His potential beautifully on the lead that's in the bottom on the left, and you can see the RV paced ECG on top, QRS 170 with a His bundle. The activation sequence normalizes. We got good narrowing, and we expect a much better result with this configuration. So it's a new thing that we're using, but the potential for His bundle pacing in heart failure and inappropriate device management is tremendous and very exciting. So in conclusions, if you meet someone who has criteria for ICD, this is a very high-risk patient, and you should really have a discussion in an encouraging way for that person to accept the therapy. Guidelines and docs are failing sudden cardiac death victims. Transvenous ICD, atrial lead, only if you need atrial pacing. We can think about the subcutaneous ICD. We can appreciate the LifeVest. I think, unfortunately, it's just 2B for the traditional waiting periods, 2A for transplant or somebody with an infection. We should be worried about ventricular pacing in our ICD patients. If you see high ventricular pacing burdens, think His bundle pacing, think LV lead upgrade. For someone who truly meets criteria for CRT, recognize this can be transformational heart failure therapy if it is done appropriately and that device is fine-tuned. I worked for Providence. I gained the distinction of being the EP who referred more patients to cardiac surgery for epicardial leads than anyone else. That was kind of in my data. And that's because if I can't get good LV lead or it's not giving good electrical resynchronization, it is worth sending that patient to surgery for an epicardial lead. Talk to a surgeon you know. He'll make sure it's really in a basolateral position and you can get a beautiful pace vector. And you can turn a non-responder into a responder in many cases. So it's worth the doc paying that attention and taking that step, even if Providence will put your numbers up on the board and let everyone else know that that's what you're doing. So it's fine, you know. To me, it's a sign of responsibility rather than a crappy lead implanter. So devices are now MRI safe. We should offer MRI safe devices to everybody. Everyone pretty much has that. The S-ICD has it now too. Biotronic, Medtronic, full suite MRI, so that's a no-brainer. And Boston Scientific recently gained indication for their CRT, so we should be offering this. Thank you for having me at your conference. I'd like to invite you to mine.